Hey folks, just want to note that it is 4:15, but I just want to give everyone a chance to hop on, so we'll get started here in a minute or two. Thanks so much. All right, I think we can go ahead and get started. Good afternoon, everyone. My name is Melinda Southard, and I serve as a Deputy Director here with the Nevada Health Authority for Community Engagement and Workforce Development. And one of the areas that I oversee, of course, is the statewide healthcare access and recruitment program. So just want to thank you all for joining the public workshop late this afternoon. We're excited to share a lot of good information with you. So with that, I'll go ahead and get into the slides. So of course we have an agenda. So first we want to just do a little bit of level setting, just give a brief overview of the statewide healthcare access and recruitment program. Then we'll move into a review of the draft initial assessment and report that NVHA is working on. Then we'll move into the outline for the request for application process. And then, of course, review the draft RFA for the SHARP program itself. And then we'll have an opportunity for questions and discussion at the end of the slides. So appreciate you all holding your questions until the end, and looking forward to answering those questions for you guys. All right. So first we'll get into a little bit of an overview about the statewide healthcare access and recruitment program. So this program came out of Senate Bill 5, otherwise known as SB 5, from our 2025 special session of the Nevada legislature. So the goals of implementing this program is really to support workforce capacity and sustainable healthcare in our state. So Senate Bill 5 in and of itself did create a new state general fund account. That's what the SGF stands for. So there's a new account to hold the funds that support this program. The Nevada Health Authority is assigned with developing the grant program that's associated with this program. And it also wanted to note here that we do have IFC, or Interim Finance Committee, approval is required on all SHARP grant awards. So that means that, all of the requests for, or actually all the applications that are received, the Nevada Health Authority, reviews those, and then there are selected grants or applications that will go forward for recommending for funding. So the Nevada Health Authority has to take those recommendations to the Interim Finance Committee for final approval. There is a one-time appropriation of $60 million in state general funds appropriated to the SHARP account. So we do have those funds available. They will not be available, though, until July 1st of this year. So right now we're just operating off of our normal operations. And then the bill also did allocate 3.5% to the Nevada Health Authority of the funds in the account to be able to administer the SHARP program. So some of the requirements that came out of the bill as well, we do have that biennial required SHARP assessment and report. So every other year, the Nevada Health Authority is responsible for getting that information out together and out to the public. And in addition, we do have very specific requirements for entities that are eligible for funding for this program, as well as projects that are eligible to be funded through this program. So then the implementation procedure of the Nevada Health Authority, we are compiling that initial assessment that's required before July 1st of 2026. So Dylan and Maddie will get into that in a little bit here. So they're also developing that report that is coupled with that assessment. And then the request for application, or RFA process, will be built upon the information that comes out of that assessment and report to then solicit for applications from you all to be able to subgrant out these funds. And then we also are asking for staff within the Nevada Health Authority to support administration and sustainment of the SHARP program. So I also wanted to provide a quick overview of some of the different workforce programs that we have in the Nevada Health Authority. So the SHARP program is just one of the healthcare workforce opportunities that we have available at this point. So I just wanted to go through these really that we do have a graduate medical education, or GME, program in the state. This has been around since about 2014. This program is statewide, and in this state fiscal year, so SFY 26, we have $15.8 million available to support creation, expansion, or retainment of residency programs and postdoctoral fellowships that are all approved by the Accreditation Council for Graduate Medical Education, otherwise known as the ACGME. And we did have the Advisory Council for GME did just meet earlier this month and provided their recommendations to the Nevada Health Authority for which applications should be funded. So the next step is for the Nevada Health Authority to review those recommendations and get to working on issuing those subawards by June 30th of this year. Next, we have the Rural Health Transformation Program, or the RHT program. One of the initiatives within the Rural Health Transformation Program is Workforce Recruitment and Rural Access Program, otherwise known as WRAP. We did allocate a vast majority of the funding that the state receives every year in this grant towards workforce, because we know that it is such a need in our state. The Rural Health Transformation Program, though, is limited to rural and frontier areas of the state per those HRSA definitions. So I did provide a link there that you can review and see, which areas qualify as rural and frontier in our state. So under this particular initiative, we have almost $72 million available in this first year, otherwise known as Budget Period 1, or BP1. That is from December 29th of last year all the way through October 30th of this year. So that's the budget period. And the next steps for this one is that the subawards are to be issued no later than October 30th of this year. And that's due to federal deadlines that we have to meet, where the state has to obligate all of those year one funds no later than October 30th. And then, of course, we have the SHARP program. The SHARP is available statewide. This year next year, I guess, state fiscal year 2027, which will start on July 1st of this year. We will have nearly $58 million available. And the reason why that is less than the $60 million is, of course, because we have that 3.5% available to the Nevada Health Authority for those administrative costs. And of course, the next steps for the SHARP program is that we are looking to issue the RFA before August 1st. However, my goal is to get the RFA published by July 15th. So fingers crossed, working on that. And then all projects recommended for funding, of course, will be subject to IFC approval. So with that, I'm going to turn things over to Dylan to go over the draft assessment and report for 2026.
Thanks, Melinda. Hi, everyone. I'm Dylan Malmlove, and I serve as the Executive Director of the Nevada Patient Protection Commission. And I'm joined by Madison Lope from the Office of Analytics and our Chief Biostatistician. Next slide, please. As required by SB 5, the Nevada Health Authority is required to conduct an analysis of the healthcare workforce in Nevada and determine the most critical shortages and unmet needs for health technology and therapies and workforce. The assessment aims to answer two broad questions: how many providers are practicing in the state by region and profession or specialty, and which professions or specialties and regions are experiencing the greatest unmet need. Next slide. There's been a significant amount of work in this space to this point, and in our analysis, we reviewed the literature to gain an understanding of the current trends and themes. Those sources can be found in the appendix later in these slides. But at a high level, the common themes that emerged were persistent and growing healthcare workforce gaps, that while there has been meaningful growth in the licensed healthcare workforce, the provider to population ratios remain well below national averages and may not be keeping up with the population's needs. Since 2000, the state's population has grown 63%, exceeding national growth rates, starting at about 2 million in 2000 to more than 3.3 million in 2024. During that time, population demographics have shifted as well. The population is aging, the median age has increased, and the share of residents over 65 is projected to expand substantially over the next 2 decades. That group is associated with higher healthcare utilization and needs. Further, the average age of physicians in the state is 54.8, and about 44% of active physicians are over the age of 55, raising concerns that workforce attrition or retirement may outpace our ability to train and recruit new providers. There are also geographic challenges. Carson City and the state's 14 rural and frontier counties together account for just 6% of the physician workforce and 11.4% of the state's population, spread across about 86% of the state's total land mass. These factors may contribute to access and quality gaps in the state, where Nevada ranks among the bottom states in metrics tied to coverage and access at 49th and prevention and treatment at 51st, according to the Commonwealth Fund State Scorecard. Some metrics that contribute to these poor health rankings include 27% of adults without a usual source of care and 15% of adults who went without care because of cost in the past year, and 42% of children without a medical and dental preventative care visit in the past year. Each of these factors help add context to the workforce shortages and identification of critical areas of need. Next slide, please. I wanted to quickly highlight our methods, beginning with kind of a statewide workforce supply analysis, showing the workforce supply across selected professions and physician specialties. In each of these tables, we'll show the active or licensed providers per 100,000 population, comparison to neighboring states including Arizona, New Mexico, Utah, and Colorado, and national benchmarks, location quotients, and estimated workforce gaps to reach national parity. And finally, county-level provider density maps for those selected professions. Using that data in our literature review, priority areas were selected, and those include primary care, behavioral health, and medical specialties. Within those shortage areas, we did a deeper dive looking at health professional shortage area designations and active Medicaid providers. Active Medicaid providers per 100,000 Medicaid beneficiaries, and the geographic variation in provider participation for those focus areas. We use data from multiple sources across the study, and those are listed here as well. Next slide, please. This first table shows selected professions across the healthcare workforce derived from the Bureau of Labor Statistics data from May of 2025 and the AMA physician professional data, and shows by profession the active providers in Nevada, then the rate of providers per 100,000 for Nevada, and for comparison states across the Mountain West, selected for their geographic proximity, demographic, and geographic comparability, and their similar Medicaid context. Those included Arizona, New Mexico, Utah, and Colorado, and then national per capita rates, which are used to calculate Nevada's location quotient, which take the per capita rates from Nevada divided by the per capita rates in the US. A location quotient above 1 means that you have more than the national average, and below 1 means you have yet less. Using that rate, we're able to calculate the number of additional providers needed to meet national rates. This slide helps show that Nevada's challenges aren't isolated to one profession, but are broad and systemic across much of the care continuum. There are a lot of numbers over the next few slides, so I just want to point your attention to a few areas. First, within the mental and behavioral health space, there are concerning shortages across community level frontline behavioral health providers like counselors and therapists, and needs among more acute care professions as well. For physicians and physician assistants, Nevada is among the bottom 2 states in regional comparison and fall short of national averages, with about 2,441 additional physicians needed and about 300 additional physician's assistants needed. Among nursing professions, data indicate substantial gaps and shortages across the Mountain West. It seems that Nevada's challenges aren't unique, but consistent with the need across the region, where about 4,000 additional registered nurses would be needed to reach national parity, as well as 2,800 LPNs and 4,600 CNAs. Another important takeaway is that the shortages aren't uniform. Nevada performs relatively better among nurse practitioners, which may reflect how the state's kind of adapted to physician shortages through expanded use of advanced practice providers. At the same time, though, those gaps in physicians, registered nurses, and behavioral health specialties suggest challenges across profession areas. Next slide, please. This slide continues a similar pattern, although shortages here are often more moderate and uneven across professions rather than across categories. A notable takeaway is that Nevada tends to perform better in professions tied closely to acuity and hospital-based care, like respiratory therapy and paramedics, where Nevada is closer to or at national averages, which could reflect more targeted workforce investment, hospital demand, acute care needs, and expansion of acute care capacity over time. In contrast, many of the rehabilitative and supportive care professions remain below national benchmarks, including things like physical therapy, speech-language pathology, occupational therapy, and pharmacists. These are increasingly important for managing chronic disease, aging populations, disability services, and post-acute recovery. While they don't often receive the same attention as physician shortages, they play a large role in long-term health outcomes. Next slide, please. This map helps contextualize the workforce shortages we discussed in the previous slides, showing how providers are distributed geographically across Nevada. It contains selected healthcare professions, and the full table is available in the appendix of this presentation and is from licensure data available on the Nevada Instant Atlas. Darker blue here indicates that a higher proportion of providers. Sorry, my light is on a timer. And then the lighter blue indicates fewer providers. While shortages are often framed as a rural issue, this map shows that challenges are broader, both distribution and supply. Provider concentrations are highest in urban areas because that's where the majority of Nevada's population and healthcare systems are located. However, Clark County, despite having the highest number of providers, still has relatively low provider to population ratios compared to Washoe County and national benchmarks. The map also reinforces that frontier and rural communities face access challenges, and in many of these areas, there aren't just long wait times, but limited or absent local access altogether, requiring them to travel long distances for care. Behavioral health disparities are particularly pronounced geographically and consistent with some of those earlier results and gaps. Psychiatric and behavioral provider supply is very thin across much of the state, including some of the urban regions, which suggests a broader statewide workforce pipeline and retention challenge rather than isolated gaps. I also want to point out that this is based on licensure data, so it may not be where care is actually delivered. Some providers may practice part-time across multiple locations through telehealth or in another state. So the effective provider supply available to patients may be a little bit different than this map represents. Slide, please. This slide starts to show where Nevada's physician workforce gaps are most concentrated. The shortages are broad and extend across primary care, behavioral health, and many of the core medical specialties. Primary care is a clear example, representing about 40% of the total physician workforce gap to the national average. And this has important implications as primary care is often the front door to the healthcare system. And when capacity is limited, patients may delay preventative care, experience longer wait times, or rely more heavily on acute or intensive care settings like emergency departments for routine care needs. The pediatric workforce stands out in particular. Nevada's pediatrician supply trails both neighboring states and national benchmarks, which may impact preventative services, developmental screening, and coordination of care for children with complex needs. And we may be seeing the impacts of those shortages in the state's health rankings, where the state ranks last in children with a medical home at just 32% with medical home status, which is having a usual source of care and support navigating referrals. 50th in children without a medical and dental preventive care visit, at about 2 in 5 without a visit. Behavioral health shortages remain among the most severe findings in the analysis. Psychiatric and especially child and adolescent psychiatry show some of the lowest provider ratios on the slide. These shortages are often associated with longer wait times, limited access, and greater reliance on emergency or crisis-based care. And again, these shortages may contribute to Nevada's poor mental health rankings, where the state is ranked 51st, according to Mental Health America. The specialty care data also suggests that Nevada may still be developing tertiary and subspecialty capacity. Fields like cardiology, pulmonology, neurology, gastroenterology, hematology, and oncology all remain well below national averages as the population grows and ages, and demand for these specialties will likely to continue increasing, particularly given the rising chronic disease and cancer prevalence across the nation. Next slide, please. This slide continues to show that picture of the physician workforce, focusing more on hospital-based diagnostic and surgical specialties. Compared to the prior slide, Nevada performs somewhat better in several acute and hospital-centered specialties, but those gaps still remain. Emergency medicine and anesthesiology are relatively closer to national benchmarks. Pathology and radiation oncology remain notably below national averages, consistent with some of the findings from the prior slide, suggesting ongoing challenges in cancer care infrastructure. The surgical specialties show a similar pattern of relatively more moderate, but still widespread shortages. Some of the largest relative gaps appear in specialized surgical fields like vascular and neurological surgery. It's also important to remember that these counts may not reflect the effective supply of physicians in the state. And taken together, these last two slides kind of reinforce that the state's workforce challenges span across the full continuum of care. Next slide, please. Again, this